All right, welcome back to another PCBH Corner. I'm so excited to be joined by Alan Francis, who probably many know, that has done a lot of different writings. I got to know him by his book, Saving Normal, that I'm hoping to talk a little bit about. And I know we're kind of on a time we want to make the most use of this. So, Dr. Francis, I wanted to jump in. And my first question is probably a big question that I'm excited to see where your mind goes is, after reading that book, Saving Normal, throughout this, I kept asking, what was the moment that you realized we might be getting this wrong, or we might be heading as a field of psychiatry, of psychology, and particularly with diagnosing, then we might be heading to a place that is getting to be unworkable, that we might be going down a path that we don't necessarily want to be going down. When was that moment that you realized that?
Well, he was a resident in the late 60s, and we were way over-diagnosing schizophrenia and giving people enormous doses of antipsychotics, keeping them in the hospital for a really long period of time, warehousing them. And in 1982, I wrote a paper called No Treatment as the Treatment of Choice. So that even though I was part of DSM-3, I was always sort of the skeptic on the overuse of psychiatric diagnosis. I always felt we should underdiagnose rather than overdiagnose. It's always easy to increase the severity of a diagnosis. Once a person gets a label, it haunts them for life. That overdiagnosis leads to tons of medication that people don't need. So I've been a kind of cautious. I have great respect for diagnosis, and I spent a lot of my life working on it. It's done well, done accurately. It's life-enhancing and sometimes life-saving. But overdone and done carelessly, a diagnosis can lead to as much tragedy as the underlying disorder. And so my emphasis is on cautious, careful, conservative diagnosis.
So let me ask you this, because you talk about this in the book when you oversaw the development of the DSM-4, about what your hope was for the DSM-4, and then the rippling out effect that just was unintended. And then obviously the DSM-5, unfortunately, maybe having that even worsen. For people working in primary care, which, as we said, is the audience that largely works in it. Primary care, as you know, it's fast-paced. It's where the majority of people that are receiving psychotropics get prescribed. A lot of diagnoses are rendered very quickly. What advice would you give people that are working in primary care to not continue to maybe have this tendency of overdiagnosing?
I think primary care is really the main arena for psychiatric care. So 80% of psychiatric medications are given in primary care. Only 20% of psychiatric medications are given by psychiatrists. And particularly benzodiazepines, 90% of benzodiazepines are given in primary care, 80% of antidepressants, 60% of antipsychotics, and 50% of stimulants are given in primary care. So really, primary care is a much more important arena for psychiatry than specialty psychiatry. So I couldn't emphasize enough how important is the work of the people that you're helping to educate. I think that primary care is also the hardest place to diagnosis. It's the hardest place partly because there's the least time. It's the hardest place because the primary care docs themselves usually have not had much training in psychiatry. It's the hardest place because they only have 15 minutes for or less, and they have to fill out records for each patient, and they have to get the patient out happy. And the easiest way to get the patient out happy is to write a script. The hardest because most primary care practices don't have behavioral health components. Your people are doing a very important service. In many practices, that service is just completely unavailable. It's the hardest because there's no harder place to make a diagnosis than in primary care. That I've seen hundreds and hundreds of patients who got a psychiatric, maybe thousands of patients who've gotten a psychiatric diagnosis who didn't need one. Many of those patients got that psychiatric diagnosis in primary care. The quick and careless default psychiatric diagnoses when there's medical uncertainty is a global problem in our system, that if the doc can't explain it on medical grounds, the assumption is always, well, it must be in your head, it must be a psychiatric problem. On the other side, very many problems that look psychiatric are really medication or medically induced. My first thought with anyone who has a fresh psychiatric symptom who's on medication particularly in the elderly, is it's a medication side effect.
Ah, interesting.
Much more likely for an elderly person to have a late onset of medication-induced psychiatric symptoms than for it to be a primary psychiatric disorder. And my second thought is going to be medical problem. I will be thinking of a primary psychiatric disorder as only a third possibility in anyone, past, youth, because so many people are taking drugs for medical problems that cause psychiatric symptoms, and because medical problems become more and more common as people age.
Dr. Fritz, I love you saying, because this is something we talk about with both our psychology trainees and our family medicine residents, the importance of understanding base rates about what most likely is producing something or being seen. And I love how you've been saying that, like when I start to see symptoms at a certain age, this is almost the algorithm that I'm going through to make sure I'm ruling out what is the more likely thing rather than a psychiatric diagnosis of what's going on. I love that you said that. That's great. So for you, it seems like the suggestions for people working in primary care is maybe slow down a little bit. Don't give this diagnosis automatically.
Slow down a lot. I mean, I think that in the two age groups, in terms of base rates, where diagnoses are most often wrong are kids and the elderly. So in kids, there's a huge tendency to way overdiagnose. So many of the problems in kids are due to acute stressors, environmental difficulties, family difficulties, school bullying, all sorts of problems that kids have get translated into, oh, they have a severe psychiatric problem, where very often they'll be outgrowing it, either because they've outgrown the situation or because life experience has made them less shy or less impulsive. And that overdiagnosing in kids is particularly bad because they get medication they don't need, and they get the label often for life that will do much more harm than good. And similarly with the elderly, the idea that most problems in the elderly are caused by new onset psychiatric disorder is just wrong. Most psychiatric problems in the elderly are caused by medication or medical side effect of the illness. And so being aware of the fact that not everything that looks like a primary psychiatric problem is a primary psychiatric problem, underdiagnosing, taking time. You can't do an evaluation in 15 minutes or 45 minutes. You can't do an evaluation in one visit. That very often you have to take the time of seeing someone over a number of visits before you can make the diagnosis. And the trouble with the insurance system is that it tends to force a diagnosis well before a person could reasonably and carefully make one. This is crazy for the insurance companies, because what happens is that people jump to diagnoses and to treatments that will maybe take years of medication and visits. It's expensive to overdiagnose, and forcing diagnoses early forces overdiagnosis and overtreatment. It would be much smarter if they paid more for evaluation visits, so that you wouldn't have to have a diagnosis. We're evaluating an individual, very often 3 or 4 visits, evaluation visits, and you realize that the psychiatric problem either doesn't exist at all or is transient, and that you won't need medication for a lifetime. The advice psychotherapy for most mild to moderate psychiatric problems, the use of advice normalization psychotherapy is much cheaper in the long run than starting a pill. It's very cheap and easy to start a pill on a first visit, but then the person may be taking that for years or decades, getting side effects, no positive effect, and all the expense of those visits. Psychotherapy and advice and normalization given at an appropriate time, most people who come in with acute stress problems will get better on their own.
And I love the research that's coming out a lot from Europe that thankfully is starting to infiltrate some of our point of care resources, like Up to Date, about watchful waiting, right? Which really is almost kind of like active waiting, as you said, like normalizing, maybe giving some, setting some goals, and particularly for mild and moderate depression, people get better. It just, the symptoms largely resolve after that.
The placebo response rate for severe psychiatric disorders is under 10%. The drug response rate may be 40 to 50%. So you're getting like a 4-to-1 advantage to active medication with real psychiatric problems. For mild psychiatric problems, the placebo response rate is over 50%. The active drug response rate may be 70%. So you're getting a very tiny advantage of active drug over placebo, but the patient doesn't know that. So if the doc sees the patient for 15 minutes, it's on the patient's worst day. That's when people come to doctors. The patient leaves the office with the medication. The odds are at least half they're going to get better in 2 weeks without the medication. But once they take the pill, they will attribute the benefit to the pill rather than the passage of time. And they'll feel that they have to stay on the pill to stay well. Sometimes the person stays on the pill long enough to have withdrawal effects if they stop it. And if they have withdrawal effects when they stop the medication, they'll assume that it was a relapse of the original problem, not the withdrawal effect of the medication. So it confirms the idea that the pill is crucial to their existence. So you get many people who come to the office with a problem that would get better in 2-3 weeks on its own, placebo effect, expectations, passage of time, removal of stress, support, that doesn't need medication, absolutely doesn't need medication. But a month later, when they've taken the pill, they'll say, oh, the pill made me better.
Right.
And 2 years later, when they try to stop the pill, it may have withdrawal effects. And when they feel symptoms again, they'll say, aha, I'm sick. The pill made me well. I have to stay on the pill. So many people stay on pills for years or decades who never really needed them. It's important to use pills as a last resort with mild to moderate problems, to do the advice, normalization, support, parent training, psychotherapy first, and a pill only as the last resort. And that gives time also for the placebo effect to kick in, because all of this attention will help people get better on their own. Time will help them get better on their own. And then you're not forcing them into years and years of treatment.
Again, you're getting me hyped with all these different things that you're saying. I'm so excited for the viewers to watch this. Two additional questions my mind went to. One was, what do you make? And I know you wrote a blog post about this, particularly with the guidelines that came out about potentially screening children for anxiety, about what the ripple effect of that's going to be. What do you make of a lot of these guidelines that come out, particularly that get enacted in primary care about screening people for specific symptoms and pathologies, and now are even part of like quality aims and metrics that healthcare centers have to do? What advice would you give health centers that, hey, yeah, this is recommended, these are the guidelines that are coming out, but make sure that we don't use it in a way that continues to go down this road that we know isn't workable?
I think a lot of the guidelines for universal screening, especially in kids, are just crazy. One of the things I've learned is you can't trust experts to make guidelines in their particular area, because they will always expand their area. They will always see the benefits of what they're doing in expanding their diagnosis. They'll never understand the risks and unintended consequences. They never work in primary care. No expert in psychiatry has spent a lot of time, very few have spent a lot of time in primary care. They decide things based on their own experience in research clinics that are highly specialized, have lots of time with each patient, have highly selected patients. The patients who get to see experts are very different than the patients who are seen in primary care. The base rates of disorder in a expert clinic is going to be very high. The true base rate of a disorder in people presenting in primary care is going to be much lower. You make many more errors, false positive diagnoses in primary care with the same guidelines that may work in an expert clinic. So the problem with universal screening of kids is that you get an enormous number of false positives.
Enormous
number of false positives. And a false positive can be a very dangerous thing, because it leads to labeling the kid, stigmatizing the kid, and worst of all, often giving him medication. So I'm very much for screening in high-risk populations.
Gotcha.
Pregnant women who've just delivered kids with a high incidence of psychiatric problems that can be harmful both to mother and child around pregnancy and childbirth. That's a perfect place where a primary care doc should be asking every woman about psychiatric symptoms on every visit during the pregnancy and after the birth, to make sure that she's not going to get a depression or a psychosis that may be very harmful to her, very harmful to the child and to their relationship. High risk population, high base rate of problems, terrible consequences, all make screening useful. When you want to screen every kid in the world, every child, the screenings are recommended at ages, in some places as early as 4 or 5, for mental health disorders. you're going to get a tremendous number of kids who are going to be mislabeled as having mental health disorders. And the benefits to the small number who may be identified properly do not outweigh the tremendous risks to the large number who are going to be misidentified, that the false positive problem makes universal screening in psychiatry not just wasteful, because it leads to a misallocation of resources, but also harmful to the people mislabeled. And the other context of this is we're terribly neglecting the people who really have psychiatric problems. So we have 600,000 people in jail or living on the streets because we don't provide them with psychiatric care. We're not taking care, there are not enough child clinicians in America to take care of the existing real psychiatric problems in kids. We don't need to create a new false positive cadre of kids who will to whom we will misallocate resources from the kids who really need treatment, who have declared their illnesses, who desperately need help, and we can't help them. And if we add more kids, they'll become even more lost in the noise.
You know, it was something that I love that you wrote about in the book, and you wrote in blog posts about this exact thing. It's like, if we actually look at the people that we're treating right now, it's not the people that actually probably have severe mental illness. The large majority, you know, I know this term, people don't like this term, but this worried well kind of aspect, and we're providing care to people that it's like, there's a lot of people out there that do have these very impactful, impairing concerns and pathologies, and the care is not actually getting to them. And I love how you just frame that it's like our want to indiscriminately screen is actually creating even more of a chance of us missing and providing treatment to those people that actually might need it and might benefit from it.
The stats are very clear. So in the US, first of all, any study that discusses the rate of psychiatric disorder in the general population misstates the actual rate. The studies are all done by telephone, by non-clinicians. If the person has any symptoms at all, they get a diagnosis. And usually it's reported about 25% of the population has a psychiatric disorder in the previous year. This sets in mind, if I'm a primary care doc or if I'm a psychiatric psychologist working in a primary care setting, half the population has a disorder, that makes me think a high base rate, I should have a high index of suspicion. In actual fact, most of those people don't, because you have to have a clinically significant amount of distress or impairment before you get the diagnosis of a disorder, not just symptoms. The telephone interview done by a layman doesn't judge clinically significant. So the 25% should be read as an upper limit, not as an actual rate, but most people miss that step. The percentage of people in the US who are taking a psychotropic medication is 20%, 1 out of every 5. That's a ridiculously high number. It's an absolutely ridiculously high number. So and when you look more microscopically at, let's say, ADHD, the clearest result in the entire universe is the overdiagnosis of ADHD. There have been about, I don't know, at this point, maybe 15 studies in 10 different countries with maybe tens of millions of kids. And the most consistent finding in all of psychiatry is that the birth date of a child is the best predictor of whether they get an ADHD diagnosis. That the youngest kid in the class, particularly boys, the youngest kid in the class is almost twice as likely to be diagnosed as ADHD as the oldest kid in the class. And there's no way of understanding this. It just hits you in the face. The only way you can understand this is that we're taking immaturity, the kid being the youngest kid in the class, and giving it a mental disorder label and saying they have ADHD. And how do we interpret why this happens? Well, if you have big classes, insufficient teaching, the teachers are going to be referring to parents, those kids who are having the most trouble, struggling in class. And those kids who are struggling in class are likely to be the youngest kids because they're the least mature, especially boys who mature later. And so those parents, my kid has ADHD. No, the kid really is just the youngest kid in the class. But we're taking an educational problem that if you have kids who are a year different, almost a year different in age in the same classroom, that the youngest kids are going to have more trouble keeping up and behaving than the oldest kids. And we're taking that educational problem and turning the youngest kid into a mental patient, and then often enough giving him Ritalin as a solution.
And you think about the rippling out effect of that, as you said, like how that individual then starts to see themselves within their context. And then, you add, this is a thing that, my mind has found so fascinating over the past 3 years with COVID that has come on. It's like, if you wanted a recipe for depression and ADHD symptoms, it's COVID, right? I mean, about, the scare and the explosion of diagnoses that are going on now. It's like, we really probably should just pause for over a couple of years to make sure we know what we're dealing with, even from COVID and those contextual variables that are going on there.
I think it's a no-brainer that COVID itself can cause psychiatric symptoms. I think it's a no-brainer that being isolated at home and often in very difficult conditions, the stress of that can cause psychiatric symptoms. So it's no surprise that psychiatric symptoms have increased and that some of those symptoms represent real mental disorder. But we should also realize that not every human distress is a mental disorder. That we have, through evolution, certain emotional reactions of anxiety and depression that come as a realistic response to external stressors. And that labeling everyone who felt anxious or sad or socially isolated during COVID as mentally ill misses the fact that this is a social problem. It's not a mental disorder problem in the individual. And psychiatry is not the cure for every problem, every emotional distress. There's not a pill for every problem that humanity faces. And by medicalizing all emotional distress, we often miss the social context. If we wanted to improve the mental health of America most in the shortest period of time, it wouldn't be doubling or tripling the number of mental health workers. It would be providing a fairer system economically. The biggest causes of mental illness, the external stressors that are the most disabling for people, are socioeconomic. The US spends something like 2 to 3 times as much on medical care as the rest of the world, the rest of the developed world. And we have lousy results overall in medicine. A lot of this has to do with the waste and the corruption in the medical system. But it also has to do with the fact we get lousy outcomes. Why? We overinvest and invest poorly in medical care. We underinvest in social programs, a social safety net. And countries in Europe spend as much total as we do on medical care and social safety programs combined, but their ratio is different. They have less expenditure on medical care, more on social safety net programs, and they get much better outcomes on medical disorders. Forget psychiatry, on medical disorders. Maybe 80% of outcome in medical and psychiatric problems is due to the social context in which the problem occurs, it's caused sometimes, and the way it's handled. So we have a great underinvestment in the US in taking care of people and improving their lives, a great underinvestment in psychological services in the US. Most parts of the US, you can't find a psychologist. You can't get a psychiatrist. There's no availability. Everyone's taken. We don't provide caring services, and we over-medicalize problems and give way too much in terms of medical treatment, medical testing and medical treatment.
Dr. Francis, again, I could talk for days with you about this topic. And the one last question I wanted to ask before we wrapped up, because I found a blog post and I loved how you talked about this. And I wanted to see if you could just expand on this briefly about what you meant about the blog that you wrote about patient-centered versus lab-centered personalized medicine, and about how this saying about personalized medicine also kind of goes along with what we're talking about of kind of overdiagnosing and what that is looking at. Can you talk briefly about the differences between those two and what you would hope the healthcare field would be moving towards?
One of the unfortunate things about American medicine is that it's a for-profit system where labels are thrown out less because they have clinical meaning and more because they have marketing appeal. So personalized medicine has become the label of the last 15 years. And the idea is that we're going to really understand the genetics of each person in such a way that we'll have a personalized treatment plan that will not be what everyone else is getting, but just for you, and will be triply expensive. And that what we do is more personalized than what the next guy does. So come to us, don't go to him. makes us not just cynical in terms of money grabbing rather than really caring for people, but also ironic is that there's no medicine in the world that's less personalized than ours. There was a great cartoon with a doctor facing his computer and the patient looking at the back of his head and saying, this is American personalized medicine. The doctors no longer have time to talk to patients. The rush, it's factory labor. The doctor's given 12 to 15 minutes to complete the visit, maybe also write the record. They don't do it during the session, they have to do it at night. They don't get to know their patients. They have huge panels. The doctors are switched on every visit. Getting to a doctor is the most impersonal thing in the world. The call centers that lead to an appointment are often, wait on hold for 30 minutes before you get your appointment. Everything about the system in American medicine is impersonal. And I think if we had a true personalized medicine, it would be that the visits would be longer. If we could do one thing that would make primary care better, it would be longer primary care visits, smaller panels with people who get to know their patients. We'd have many fewer specialists and many more primary care doctors. The specialists have controlled medicine in America from the very beginning. And so they decide which specialties get the most money, which specialties get the most emphasis in medical school. We have a terrific disproportion of medical students going into specialty training because those are the most powerful departments in any medical school, and because the reimbursements, because they all usually help to control who gets what, are very disproportionate with people who do specialty services getting way more than they should be getting for procedures, and people who do primary care getting way too little to spend time with patients. If we were to do real personalized medicine, it won't be some fancy genetic study that results in a $100,000 a year treatment for a few people that may improve their care. Real personalized medicine would be spreading out to everyone, where there's much more time with a primary care doctor and with the people that you're particularly helping to educate, the people who work with primary care doctors, behavioral health workers, that try to bring some personalized medicine into practices that often lack it otherwise.
And I loved even in your blog post about how we introduce ourselves to someone in a waiting room, how we, if we're running late, how we acknowledge that and we apologize. That becomes this continuous relationship and really can be healing, and is that personalized medicine. I loved.
The last thing I'm going to say is that I've treated people, I always worked in emergency rooms. I've treated people for 15 years and had no impact on their lives. I've seen thousands of patients for 15 minutes in an emergency room. That's something that I don't remember. Had them come up to me years later and say, doc, you said something. You probably don't remember. You said something that changed my life. That's an important lesson. The lesson in that is that you can never take as routine any meeting with any patient. Maybe your 15th patient of the day, you're tired, you want to go home. It's just another patient. From the patient's point of view, meeting you might be the moment that changes their life. And you should always be working with every patient with the thought, what can I say now that will make a difference? Don't just think about the forms you have to fill out. Is there something about this person's life and where they're situated, what the stresses are? If I give them this particular insight about it, this cognitive reframing, this piece of advice, will that help change them? And I think it doesn't always work, and maybe it doesn't even often work, but we should always have that excitement with each visit that I can do something that will make a difference.
You made my day, because I got a full day of clinic right now after this. I'm going to be asking myself that every single time I go to see a patient. How can I make a difference in this individual's life? So thank you for that, Dr. Francis. I'm going to put in the description of this the link to your book, Saving Normal, so people can check that out and do. But Dr. Francis, my gratitude again for the work that you've done, giving us time today. Cannot express my gratitude enough.
My gratitude to you and to the people who you're working with, because they really are the heart of what's important in psychiatry these days.
I appreciate that. I appreciate it. Well, thank you again. I hope people enjoy this. As always, please, share this video widely, put comments, questions, where hopefully can get some responses to it. But I hope everybody enjoyed this PCBH Corner, and tune in until next time.
Bye-bye.
See ya.